Thank you, Gary. It truly is an honor to have you with us, and your story is inspirational for everyone with type 1 diabetes. Let me introduce now one gentleman, and then he will introduce a panel of people who are actually trying to do an awful lot to cure type 1 diabetes. It's with great pleasure that I introduce our next speaker, Dr. Henry Anhalt, who's the Chief Medical Officer for the T1D Exchange, a nonprofit organization which has created a new paradigm in medical research, fostering collaboration between patients, physicians, researchers, and industry with the goal of speeding up the development of cures for type 1 diabetes. A renowned pediatric endocrinologist with over 20 years in clinical practice, Dr. Anhalt has led pediatric endocrinology divisions at St. Barnabas Healthcare System in New Jersey and the Children's Hospital at Maimonides Medical Center in New York City. He reminded me that we knew each other when I interviewed him, and I had dark hair, and he was not so follicularly challenged, as you'll see. Please welcome Dr. Henry Anhalt.
Good afternoon, everybody. First of all, I'd like to thank the organizers for allowing me to come here and speak about type 1 diabetes and join a group of individuals, all of you who are so committed to work towards therapies for people with rare and not so rare diseases. So, let's see. First thing I think is important to do is to distinguish between type 1 and type 2 diabetes. Many of you are familiar with type 2 diabetes. It is far more common than type 1 diabetes, but due to a completely different mechanism. Type 1 diabetes is an autoimmune disease. It is not due to any lifestyle choice, due to diet or exercise. It is due to an autoimmune response that we still don't understand the reason for. It is not genetic in nature, and type 2 diabetes can be managed primarily with medications that are oral and lifestyle. There are approximately 1.25 million people in the United States with type 1 diabetes. Many people have referred to it in the past as juvenile diabetes, but it's most certainly not. It can affect adults into the second, third, fourth, and fifth decade into life. Without insulin, people die with type 1 diabetes. And you heard Gary just a moment ago talk about some of the struggles. But he also mentioned low blood sugars, and important to keep in mind that too much insulin will also cause somebody to die, and dead-in-bed syndrome is something that we all are fearful of as pediatric and adult endocrinologists. It's the most common life-threatening chronic illness of childhood in developed countries. And I think it's important to pause for just a moment and keep in mind that there are children and adults who die every day across the globe because of a lack of access to insulin. It's unconscionable, but very much true. It's growing in prevalence, and I'll show you data on that in just a moment. It spans all ethnic groups and socioeconomic status. And as I mentioned, injected insulin is the only available therapy. Major risk of life-threatening complications, including loss of limb, loss of kidneys, loss of vision. And lastly, although I'd like to believe that our cure will be available in our lifetime, I think it's fair to say that, at least in my lifetime, maybe for some of the younger people in the audience, we're unlikely to see that. The incidence is rising, and along the horizontal axis, you see three age groups, 0 to 4, 5 to 9, and 10 to 14. The vertical axis is the percent increasing in incidence, and the blue represents the United States, and in red is Europe. It's important to keep in mind that although we're seeing across all ages, the largest group that has the highest increased incidence is in the youngest group, and this is data over a period of about 10 years. Why is this happening? Lots of theories, and you know, when lots of theories are posited, one could argue that no one really knows what it is, and most likely it's multifactorial. But there have been theories about vitamin D exposure, and as you go north through Europe, you see a higher incidence of type 1 diabetes. Maybe it's exposure to cow's milk. may be, in fact, that this is a disease that, at least in part, is caused by hygiene that's too good, and that it deprives the immune system of early priming that could potentially offset some of the immune response, as we'll soon see in a moment. Another theory is the accelerator hypothesis, that perhaps excess weight or increased caloric consumption, despite the fact it's associated with type 2 diabetes, may in fact stress the beta cells, those that produce insulin, and cause them to fail prematurely. I think it's important to highlight that much of what we've seen has happened in a very, very short period of time. With the advent of insulin in 1921, you can see here on the left part of the slide the University of Toronto, and on the right-hand side, you'll see Professor Banting in the coat and his student Best. And their dog Marjorie, who in fact was one of a number of dogs who, when pancreatectomized, had the pancreas removed because it was felt to be the organ that produced a substance that circulated through the body and reduced blood sugars. When this extract was placed back into dogs with high blood sugars decreased. This, of course, led to a whole new era in the treatment of what was always a universally fatal disease. Here is a young boy, age 3. And this was a point where just about when insulin became available, this young boy would have undoubtedly died in the absence of insulin therapy. He weighed approximately 7 kilos at the age of 3. Just to put things into perspective, a 4-year-old child should expect to weigh approximately 40 pounds. Here, this child weighed about 15 pounds, and certainly representing a near-death situation. This is the same child 3 months later, where his weight nearly doubled. Well, having insulin didn't answer all the questions, most certainly not. And here you see the cumulative incidence of long-term sequelae of having what was then called juvenile diabetes in a longitudinal study done at the Joslin Center in Boston from 1898 to 1956. And what you can see here along the horizontal curve is the duration of disease in years, and along the vertical part of this graph, the percentage of cases with sequelae. And what you can see is that after a period of time, almost 100% of individuals, after about 30 years, developed calcified arteries and premature cardiovascular disease. So although we had insulin, the incidence of these side effects were much higher than they were in the background population. Well, there was some good news, and in this cohort of individuals from Allegheny, Pennsylvania, who were followed, and based on each line representing the year that they were diagnosed. So one group, line 1, they were diagnosed between 1965, 1969. Year 2 and year 3, as you see, there was most definitely a decrease in the rates of mortality. Again, promising news, but important to realize that's still much higher than the background population. Well, what could explain this? Certainly, there were improvements in technology, improvements in blood pressure control, but again, still suboptimal. I'm proud to be working with the T1D Exchange. The T1D Exchange has the largest registry of individuals with type 1 diabetes, spanning the age of 2 to age 80. These individuals have been recruited from some of the best centers, about 75 centers in the United States, and provide us a unique opportunity to understand their demographics, to enroll them in clinical trials in roughly 75 centers, as I mentioned, that we contract with, fast-tracking and facilitating site identification, patient recruitment. We can retrospectively and prospectively query the database to understand more about type 1 diabetes. Please note 3 age groups that are highlighted with the arrows, age 6, age 17, and age 30. And one would undoubtedly recognize that there is an increase in the value of hemoglobin A1C. Hemoglobin A1C is a number that represents overall blood sugar control for the last 3 months. And so those of you who've had the experience of raising adolescents would not be surprised that hemoglobin A1C rises so dramatically in that particular age group. Well, needless to say, and I always remind parents that don't worry, children will return to the human race after adolescence is over. That being said, please keep in mind that these children are in fact, and these adults are recruited from some of the best sites and the best care delivered in the United States. If I could just take one slide back. Okay, so if you take a look at the number 7.5, 7.5 along the vertical axis represents a loose, if you will, definition of where we would hope people would achieve with their hemoglobin A1C. And what you can see is that the vast majority of individuals, who many of them should be striving for a hemoglobin A1C of 7%, do not get there. And this, as you've seen before, will undoubtedly result in severe long-term complications. We're not there, and very little has changed since insulin was discovered in the 20s. So you're going to hear a lot about immunology. And what I'd like to do is help you understand and get grounded in the immunology of type 1 diabetes. And in the black, you see what was originally thought to be the cause of type 1 diabetes. And then in the blue, what you can see overlaid on top of that, some of the evolving thoughts. On the horizontal axis, you see age in years, and along the vertical axis, beta cell mass. Now, one can see that beta cell mass starts at birth at 100%, and that over time, it seems to decrease when the onset of an immunological phenomenon occurs. But what is that immunological phenomenon? Well, there have been lots of thoughts about the microbiome. We are, if you will, the sum total of the bacteria that live within us and on us, and perhaps as important as our genetic composition. So the microbiome, if you will, develops alongside. And when something now in the blue box, either a virus or diet or infection or a chemical exposure that can also be transplacental affects the microbiome, we see a risk of immunological abnormalities increasing. And as a result of that, this immunological response leads to, as I mentioned, a decrease in beta cell mass, progressive loss over time, changes in metabolic profile in blue, ultimately overt diabetes. But if you can see the black line towards the end of the graph, the black line ends, and it ends, if you will, at zero mass. But we now understand that individuals will continue to make insulin even into the fourth or fifth decade after having type 1 diabetes. This is key and important as we think about interventions that could restore or preserve that amount of function. Working off the last slide, looking at the immunological abnormalities, it would be helpful to think of three distinct phases in the development of type 1 diabetes. And as you can see on the chevron diagram, prediabetes can occur in individuals who, although this disease is not genetic in nature, can have genetic markers that put them at risk. Certainly first-degree relatives of individuals with type 1 diabetes have higher risk. And therefore, if we can intervene prior to the onset of diabetes by preventing this immunological phenomenon, that would be ideal. However, unfortunately, we're not there yet. Let's look at the second in the chevron diagram and in the third of the chevron diagram. And you will hear a bit later from my esteemed colleagues on the panel, in particular interventions that target those two specific time periods. Can we preserve residual beta cells in recent onset diabetes? Can we hope to stop the immunological damage that's destroying the pancreas' ability to produce insulin? And if not, on the third point, can we restore by providing cells that ultimately can make insulin? We've learned a lot from mice, and the question then becomes, will we Will we be able to translate the basic science information that we've learned over time to improve patient outcomes? Will it be beta cell regeneration? Will it be stem cell therapy, immunotherapies, or advanced technologies? As I mentioned in that graph that showed the slow and progressive destruction of beta cells, these cells that produce insulin in the body, that there are individuals, and we have data on this from our own patient population in the T1D Exchange. When we take a look, individuals can continue to microsecrete, and if you look along the horizontal axis, you see duration in years, and along the vertical axis, a response of insulin production to standardized challenges, and individuals will continue to microsecrete and continue to make insulin. Is this because new cells are being generated, or is it due to the fact that they're escaping destruction? You'll hear from Dr. Melton, who'll talk about stem cells. I just want to point out at the left-hand side of the curve, of the diagram, you see above the first circle, human embryonic stem cells and induced pluripotent stem cells. Both of these have promise for differentiation into mature insulin-secreting cells, and some very exciting research being done. And you see above the circles different factors that have been identified that can steer cells that have potential of differentiating, if you will, into mature beta cells that in mice models can in fact reverse diabetes. In immunomodulatory therapy, and I want you to focus only on the left side of this picture, you see what looks like a seesaw. You see a balance between the normal immune system of T regulatory cells in purple and T effector cells in orange. When there is imbalance, when there is an excess effect of T effector cells and a decrease in T regulatory cells, that immune imbalance, in fact, encourages inflammation and autoimmune destruction of the beta cells. When you infuse or you change the balance and it's restored, one can halt immune destruction, and we will hear more about that. And lastly, artificial pancreas. Many of you have heard that terminology. However, it would be irresponsible of me to conclude my talk without talking about technology. And many of you may have a preconceived notion of what an artificial pancreas is. Is that a device that is implanted in the abdomen or in the belly that produces insulin, and the patient no longer has anything to worry about? As Gary mentioned, not having to worry about high blood sugars and low blood sugars and blood sugars that are erratic and change from moment to moment, depending on how much insulin you've taken before, stress, time of day, time travel, etc. So if you can see, the first item is a sensor. This is placed under the skin, a thin wire. This wire then reads glucose values, transmits them to a device which can be read, and currently that is commercially available. You have an insulin pump that injects the insulin under the skin, again commercially available, and this is done primarily by the patient making decisions. The patient is the algorithm holder that makes the determination of how much insulin goes into the body. And as I mentioned, the complexities around that are quite challenging. But if you will, the challenge for artificial pancreas technology, which more appropriately termed automated insulin or semi-automated insulin delivery, is to remove that algorithm from the patient's mind, put it into a device, and in doing so, lighten the burden from the patient.
Type 1 diabetes has become a global health crisis, with an estimated 35 to more than 40 million people affected worldwide, and the incidence is rising rapidly in all populations. The good news is that multidisciplinary research efforts are promising to solve the diabetes puzzle. From technological approaches like the artificial pancreas to so-called smart insulin that is automatically activated or suppressed in response to blood sugar levels. And several groups are developing beta cell implants that utilize a variety of immunoprotective strategies, including stem cells and nanoencapsulation, to protect those replacement beta cells. But for our purposes today, we'll focus on several cell-based approaches aimed at restoring immune tolerance of beta cells.
I was losing a lot of weight. I noticed that me and my buddy started at the same weight when we started the trip, but after the first 2 or 3 weeks, all of a sudden he seemed really muscular to me.
Spencer Frank was 23, backpacking in Southeast Asia when he became very fatigued. His blood sugar had gone to 300. When he returned to grad school, he volunteered for a phase 1 diabetes clinical trial at UCSF, the University of California at San Francisco, under the direction of diabetologist Dr. Steve Gittleman.
So we looked at, what's the output, how much insulin can a given individual make before the treatment, and then in sequential visits back to our center over the ensuing 2 years. And about half the subjects did remarkably well. In fact, their beta cell function looked stable over that 2-year period.
What allowed the apparent stabilization of Spencer's diabetes, even in a phase 1 safety trial, is based on work in the UCSF lab of Dr. Jeff Bluestone. He and colleagues have learned how to identify and isolate from a diabetic patient a subpopulation of T cells in the immune system called Tregs, short for T regulatory, that are defective in type 1 diabetics. When these Tregs are greatly expanded in number in the lab and given back to the same diabetic patient, something remarkable happens.
We put back in 1 billion or 2 billion of these cells, so we put in a lot of them. But also we know after this 2-week period in which we grow them that they work better. We've fixed some of the defects that we identified in these patients to begin with, and the cells that come out the other end are better than the cells that we took out of the person's arm. So we're not just putting back more of the cells, we're putting back better cells.
And it looks like this resets the delicate balance in the immune system to prevent autoimmunity. A phase 2 trial is getting underway to validate the concept. A different approach to rebalancing the immune system appears to have helped young Ivan Chudnovsky, a brittle type 1 diabetic.
I went out to the playground and I played like 20 or 15 minutes, and then I ran back to my mom and sat at the bench because I couldn't walk.
When conventional therapies didn't help Ivan, his mom took him to China for an innovative and unconventional immune system reset. That approach is now being elaborated in this lab at Hackensack University Medical Center, where the innovator, Dr. Yang Zhao, has come to prepare his technique for a U.S. clinical trial. It uses umbilical cord stem cells to reset Treg cells into tolerance.
The stem cells can release the signal to the patient cells, can educate the patient immune cells, just like a teacher educated the students. They can correct their function defects, then return the cells to the patient.
Dr. Zhao accomplishes the Treg re-education by adhering umbilical cord stem cells onto the bottom of a series of stacked Petri dishes. After extracting the patient's T cells, he percolates them through the dishes, where they interact with the stem cells. What makes this process even more noteworthy is what happens when these re-educated T cells are returned to the patient.
Once those cells get back in the body, they go find all the other activated cells, and they tell those cells, wait a minute, guys, you're off base. You don't want to attack that. That's part of us, and it shuts the whole thing down.
Big difference. It's very huge difference. It's before he can play just 10, 15 minutes. Now he jump in 2 hours non-stop.
But whatever method is used to shut down the autoimmune attack, the destroyed beta cells still need to be replaced. There is some evidence for beta cell regeneration, but most type 1 diabetics will likely need a fresh supply of insulin-producing cells, something Dr. Anhalt of Sanford Health says begins with obtaining stem cells from small amounts of fat.
And then we take that as a raw material to put it in culture and drive it through the differentiation. So we will get enough cells. The cells in young people take about 24 to 30 hours to double. That means if you have 1 million cells, it takes a little bit more than a day to come to 2 million, and then it goes exponentially up. So you have bioreactors. So the lack of cells is no problem. The benefit is there is no risk of transmission of diseases. So it's not cells from somebody who might have hepatitis or some else other disease. It's your own cells. That makes it very safe.
Millions of diabetics around the world hope that one or a combination of these techniques will finally be the cure they've been waiting for.